Good morning. Welcome to the third Congress of AOSIN. I'm Dr. Yang from Taipei Veterans General Hospital. We are deeply honored to host this Congress here in Taiwan. This year has been an extremely difficult one for all of us. As some of you are aware, this Congress was to be held last May. However, due to the pandemic, it's rescheduled to today. Next. We are relieved that all the board members, chairperson, and invited speakers have been staying safe and healthy, and that we can meet one another online today. Next. I will briefly outline the proceedings for the Congress. The broadcast of the pre-recorded video for each topic is then followed by a real-time Q&A session. The presentations can be viewed on demand and accessed on our website 4 months after the event. Next. Taiwan is a beautiful island. We have lots of wonderful tourist attractions. Next. And delicious food. Next. It's such a pity that many of you cannot make it this time. However, we look forward to entertaining you in the future. Next. Please stay with us and to join the discussions. I firmly believe that everyone will learn a lot from the expertise of our guest speakers today. Next. Now, the president of AOSIN, Dr. Park from Korea, has some words to say before the start of the first session in this morning.
Dear colleagues and friends, as the president of the Asian Oceanian Society of Intraoperative Neurophysiology, AOSIN, it is a great honor and pleasure for me to invite you to the third Congress in Taipei, Taiwan. Ever since it was founded in Seoul in 2018, the second Congress was held in Osaka, Japan in 2019, which was a huge success. Now, I am really delighted the third meeting is held in this beautiful and historic city, Taipei. First of all, I am very thankful to Professor Chufen Yang and Cheng-Chua Lee and their colleagues to invite our society to Taipei. This will give an excellent opportunity for our Asian Oceanian colleagues to share knowledge, interest, and new ideas. Also in Taipei, we emphasize the interdisciplinary character of IOM, as our attendees and speakers include neurophysiologists, neurologists, neurosurgeons, orthopedic surgeons, physiatrists, anesthesiologists, and technicians from around all over Asian Oceanian region. This Congress is also held under the auspices of International Society of Intraoperative Neurophysiology, ISIN, like the second Congress in Osaka in 2019. ISIN is the only international IOM society in the world, and our society will continue to work and communicate with ISIN. IOM becomes more and more an essential part in many surgical procedures and is a fast-growing field. Given its growing popularity, the attendees will have the unique opportunity at this meeting to learn from some of the most renowned speakers and experts dedicated to the field of IOM in our region. Also, our society will continue its annual meetings throughout Asia and Oceanian countries, so please join them also in the future. I do hope all of you can enjoy the Congress academically and also friendship with your Asian Oceanian friends and colleagues in this field. Thank you.
Hello, good morning, everybody, my colleagues and friends. Welcome to the morning section. Professor Ye and I am Xiang Yu from Taipei Veterans General Hospital. We are going to co-chair this section, and I think time will be very tight. I will start my part to introduce the first author. Is that okay for Professor Ye?
Oh, hi, my name is John Yim from Brisbane, Australia. I'm certainly very grateful to be one of the chair for this session. And I'm certainly very happy for Dr. Yu to start the first session. Go ahead, Dr. Yu.
Okay. Okay, I'm going to introduce Professor Low. Professor Low is currently Senior Consultant Neurologist at the National Neuroscience Institute of Singapore and a professor in Duke News Graduate Aids Medical School. He is active in the fields of clinical neurophysiology and a regular lecturer in United States, Europe, and Asian countries. He was also the founder president of Clinical Neurophysiology Society of Singapore. His main research interests are spinal cord disorders. He has over 150 publications in the international peer-reviewed journals, including first author papers in high-impact journals, such as NEJM Neurology and Lancet Neurology. Today, he is going to give us a lecture of basic science of brain for intraoperative monitoring in brain surgery. Okay, please, Professor Low.
The topic I'm presenting today involves the basic science and principles of intraoperative monitoring in brain surgery. These are my disclosures. For today's talk, I will cover the basic principles of IOM for brain surgery, in particular resection for space-occupying lesions. I will also delve into the anesthetic aspects, pre-operative, intraoperative, post-operative activities, as well as more detail into the operative tasks. I will talk about the limitations and advantages versus disadvantages of IOM in brain surgery in relation to brain stimulation, and finally draw some conclusions. Not covered today will be on detailed aspects of deep brain stimulation or surgical aspects of intraoperative surgery for the alleviation of pain or other specialized procedures. Today's talk will concentrate mostly on the preservation of eloquent areas as well as motor function in resection of space-occupying lesions. It is important to know that in IOM or brain surgery, it is not only monitoring but also mapping. The monitoring involves continuous acquisition of neural signals, and mapping involves identification of neural structures within the operative field. The main aim is to minimize neural damage and hope for curative resection and removal with the compromise of saving function and limiting functional decline post-surgery. There are many factors that can affect the success of a surgery. This include the tumor types, age, functional status, the lesion location, as well as a lot of predisposing factors, especially the patient's clinical state. Specialized functions we hope to preserve include vision, hearing, speech, cranial nerve, as well as motor function. The sensitivity and specificity can be increased by combining multiple IOM modalities. It's important to remember that anesthesia plays an important role when you stimulate the brain directly and not percutaneously. So even if you apply direct stimulation, we know that anesthetics and anesthetic agents and neuromuscular blocking agents can lead to a general decline in the excitability of the cortex and subcortical regions, as well as the spinal cord. So similar to IOM in spinal surgery, TIVA or total intravenous anesthesia, including propofol and remifentanil, are usually the preferred combination. A neuromuscular blocking agent is often omitted after intubation. And if muscle relaxant needs to be administered, then the train of 4 technique to look at muscle twitches is often used as the benchmark. In awake surgery, which we will cover later, during the sedation, blockage of cranial nerves around the face and head and neck region may allow for painless skin incision and also provide maximum comfort and cooperation of the patient during brain stimulation and resection. So what are the general principles for awake surgery? What are the basic science underlying it? We know that the coupling of cortical mapping and anesthetic advances have led to the recent success in this form of surgery. The investigator W. Penfield first mapped the language area by means of brain stimulation and language task disruption. But there are individual variability in cortical representation, specialization, and compensatory mechanisms, especially in resecting tumors. In tumor resection, especially low-grade gliomas, the aim is to preserve function and maximize removal volume. This is a team effort and includes the surgeon, the speech therapist, anesthetist, the neurophysiologist or technician, and occasionally the neuropsychologist. Awake surgery is a challenging task, and it often results in longer operating times, special anesthetic requirements, and some contraindications, including sleep apnea, young age, uncooperative patient who are fearful and cannot tolerate certain forms of anesthesia will not have successful awake surgery. The degree of language laterality, which is important in language preservation, is found to correlate with the degree of handedness. In general, language is the purview of the left hemisphere and is well known in approximately 95% of right-handed people and up to 70% of left-handed people. It is important to lateralize language. Apart from clinical scoring, a thorough history and Edinburgh scoring, functional MRI with word generation tasks, as well as MR spectroscopy and MRI diffusion tractography and fiber tractography can help to demarcate tumor infiltration and disruption of these language eloquent areas. Ultimately, preoperative planning is important, whereby personalization and collation of data will impact on the success of the surgical process. Preoperatively, it is important to use a familiar and consistent test battery for language function as well as specialized functions. There is some controversy whether preoperative impairment is a positive or negative prognostic signs. However, subclinical symptoms, personality changes, and mood disturbances has to be expected and may prove to be burdensome in some patients after the surgery. This is an example of MR tractography where the arcuate fasciculus is shown to link the eloquent areas of the Wernicke's and Broca's areas. In this tractography, you can see that a right-sided tumor has displaced not only the cortical spinal tracts in pink, but also functional MRI, where there is activation of the eloquent areas, can be a little bit more posterior to where you would expect in a person without the tumor. This is part of good preoperative planning, whereby functional imaging can complement intraoperative stimulation. Often, bilateral activation of language areas can be seen, even if they are displaced by the tumor, and further detailed mapping of the dorsal and ventral language pathways can also be visualized in tractography with MRI. Next, I will talk about the intraoperative principles for awake surgery. It is important to obtain adequate informed consent, explanation, and team introduction to the patient who may be awake for a greater part of the surgery. When speech preservation is often the cardinal aim, mapping of cortical and subcortical areas also include motor language, motor function, sensory, and occasionally cognition preservation. Patients will be excluded if the preoperative error rate is more than 25%, according to some investigators, due to subsequent difficulty in deciding whether intraoperative error is being evoked or not. Emotional distress and agitation can be cumbersome, and sometimes the need for more sedation may result in failure of the mapping and language disruption activity. Intraoperative MRI can contribute to structural definition and provide complementary information to language mapping. In patients that are bilingual or multilingual, often testing of all languages, if possible, may be necessary, and this can be challenging and time-consuming. Other methods of intraoperative imaging include ultrasound, optical imaging, and fluorescent imaging. It's important to bear in mind the tumor limits tumor infiltration, destruction, and distortion of normal structures. Language mapping often begins by mapping of the somatosensory evoked potentials to delineate the motor from the sensory areas. The classic method of brain stimulation is a high-frequency 50 to 60 Hz bipolar pen-field technique using a nodal monophasic or biphasic current, a 1 millisecond pulse duration, and a stimulation duration of a fairly short 1 to 4 seconds. This single pulse, single train stimulation is of historical interest, and stimulating the motor system under general anesthesia may induce a tonic muscle twitch. It is often good to vary the voltage and keep the current constant so that there will be no changes in impedance. Alternatively, short trains of 5 to 7 stimuli of 0.5 millisecond duration at about 250 Hz repetitively can be used to map the motor cortex and the subcortical motor pathways which descend from the cortex. It cannot, however, be used for language and cognitive mapping because the train duration may be too short to assess disruption of language and disruption of words and sentences and naming tasks. For safety reasons, the current is often kept between 50 to maximum of 20 milliamperes because this can generate heat and lead to brain injury. The occurrence of intraoperative seizures in general from cortical stimulation using the 60 Hz technique of Penfield has been reported in up to 27% of cases. Most seizures can be easily controlled intraoperatively. The bipolar stimulation method of speech areas can occasionally cause a negative sign, while electrical stimulation of the motor areas usually cause a positive phenomenon in the form of a tonic posturing or jerking. It is important to distinguish the language of a biphasic and a monophasic current, as well as a bipolar and monopolar stimulator. The diagram shows the different types of probes. The first two shows bipolar probes, and the second two shows different types of monopolar probes. For bipolar probes, the stimulation is limited to the cortex, and the current is often between the two poles. For monopolar pole, the remote pole is away from the cortex, and stimulation is usually much deeper. This is good in activating a bigger field whereby deeper subcortical structures which govern motor function can be stimulated or activated. This is another schematic diagram which shows you that the monopolar field stimulation can evoke a current field that is much deeper subcortically, whereas the bipolar field is much more limited in the cortical region, and this is good for cortical function, for example, language and executive function assessment. This is a typical of a type of probe that combined with a sucker can also provide stimulation and suction and resection of the tumor sequentially. Intraoperatively, motor mapping can be performed in the primary motor area, whereby stimulation causes a clonic jerk, whereas a premotor area often classically results in a tonic posturing. Stepwise increase of current can be used, and a negative motor phenomenon sometimes can be due to stimulation induced inhibition of inhibited area. This may occasionally be seen during a movement task. A strip electrode, or known as electrocorticography, can also be placed on the exposed cortex adjacent to the stimulated regions to continuously monitor for after discharge activity, which are akin to focal seizures or epileptic seizures, seen as spike and waves within 5 seconds of stimulus termination. This may lead to spread of seizures and immediate action may be necessary. Subcortical mapping or mapping of subcortical structures has this problem of current spreading and the impreciseness due to different impedance of gray and white matters. And corresponding information provided by preoperative planning, tractography, MRI, and electrophysiological data and from cortical and subcortical mapping should be reconciled. After a decision is made, photography and sterile text over the resection margins of the brain can be added. This is a combined diagram showing a typical intraoperative recording whereby speech arrest and stimulation-induced clonic jerks in the right upper limb can be recorded using a multi-channel monitor. So, what is the difference between monopolar and bipolar stimulation? Once again, it is important to review the signs of post-operative management in awake surgery. Awake surgery to decrease post-operative morbidity in eloquent areas showed a surprisingly high rate of deterioration of function, usually more than 50% as a ballpark figure by certain investigators. However, at 3 months after surgery, gradual plasticity and improvement usually results in loss of function to less than 20%. Post-op MRI can be done within a 48-hour range, and it's possible to use DWI or diffusion imaging to detect ischemic changes and ascertain vascular events as a sequelae of the operation. Flare images in post-operative MRI can be optimal to look at the adequacy or resection of low-grade gliomas, as well as for contrast enhancement in highly vascular high-grade gliomas. The quality of evidence for benefits of mapping is actually quite scarce. Most evidence are class 3, and more data is certainly needed about non-language function and also quality of life measurements. Next, I will give a summary of intraoperative tasks. In the classic OGMAN protocol, prior to language mapping, we first identify the Rolandic cortex by stimulation and the sensory motor cortex by associated motor and sensory responses to stimulation and evoking motor function in the tongue, teeth, throat, and face area. Language mapping can start by determining the highest current that does not produce an after discharge on electrocorticography measurement. The current range is often less than 10 milliamperes, delivered by a constant current stimulator with 4-second trains of 60 Hz. The site selected for stimulation is identified by tagging the brain or marking with an intraoperative marker. Visual object naming to assess the presence of anomia can be used in many aphasic subjects, and it's used during awake surgery for achieving reliable language localization. It has been found that there is a statistically significant correlation between post-op deterioration and resection distance from a positive site. A ballpark figure is 1 centimeter has been regarded as a safe critical distance from the positive site where resection can be performed. Resection of a distance of less than 1 centimeter from a positive cortical area obtained by stimulation has been shown in general to cause significant post-operative deficits. However, because of brain plasticity, it may be difficult to establish whether the outcome will be the same after examining the patient 1 year after surgery. The naming task is important to note that in naming disruption, the inferior frontal gyrus and one of the areas in the temporal parietal perisylvian cortex are often found to be significantly affected. Other areas identified for this particular task are areas including the insula, the striatum, the opercular area, and the basal temporal language area. The counting task can also be used to document the speech arrest or counting arrest during stimulation. Speech arrest often occurs on stimulation of the area directly anterior to the face and motor cortex and posterior part of the superior temporal gyrus. And this can extend towards the inferior parietal lobe. This speech arrest can be complementary to the naming task intraoperatively. Other tasks that are less commonly used include auditory naming, word generation, and occasionally reading. For subcortical mapping, tumor resection starts after cortical mapping is completed. And during this stage, some preliminary studies have shown that direct stimulation can be applied at the subcortical level to identify the deep functional limits of resection. That is the white matter pathways that govern motor function. For example, a glioma removal can be performed by alternative resection and subcortical stimulation, while the patient also at the same time continues naming. The superior longitudinal fasciculus, the arcuate fasciculus, the inferior frontal occipital fasciculus are often cited to define the real surgical limits of safe resection dorsolaterally and ventromedially. Subcortical stimulation that failed to evoke language disturbances in areas when the tract is interrupted inside the tumor mass is typically seen in low-grade gliomas and remains one of the most difficult situations to manage neurologically intact patients. Other guides of resection limits which are beyond today's scope of discussion include reading, writing, calculation, visual fields, frontal eye field stimulation for saccades, and electrooculography. Other caveats for successful brain surgery include the use of SSEPs, and if the tumor or areas resected extend inferiorly, brainstem auditory evoked potentials can also be used, as well as MEPs which can be calibrated with the depth of anesthesia and neuromuscular blocking agents, similar to spinal surgery. Intraoperative EMG signals are activated immediately after cranial motor nerves are damaged or irritated. And this is important for mapping of brainstem tumors or in tumors that are large enough to involve subcortically and into the brainstem. Cranial nerves monitored include those that supply the eye muscles, the masseter, the facial muscles, the throat muscles, the laryngeal muscles, the neck muscles, as well as the tongue. In children, resection has certain challenges. The nervous system is immature, and myelination and synaptogenesis are still under development. It's important to remember that the anthropometry of children is very different, and because of the smaller head and body size, shock artifacts after stimulation may be problematic. And the fontanelle may be open until 1.5 years, and this requires alteration of the montage for stimulation and recording. And finally, the effect of anesthesia may also be different in children. Just to mention again that monopolar train stimulations provide an alternative to the pen-field stimulation method. The short train techniques or using high frequency train of 5 stimulation typically consists of trains of 4 to 9 monopolar rectangular pulses with an interstimulus interval of 2 to 4 milliseconds, corresponding to 250 to 500 Hz. Monopolar cathodal stimulation is more effective compared to bipolar stimulation in terms of eliciting motor evoked potentials in the limbs and allows predictions of distance from the probe to the cortical spinal tract. The 1 milliampere corresponding to 1 mm rule is increasingly being applied as a reliable approximation during subcortical train stimulation by the monopolar method during resection to avoid descending motor pathways. The rate of permanent motor deficits was found to be 25% for patients with irreversible MEP changes and 75% for patients with MEP loss, complete MEP loss during surgery. Mapping should be used as a primary source of functional information during surgery in relation to the cortical spinal tract, and this can be complemented by MEP monitoring with a low motor mapping threshold for uninterrupted examination of the functional integrity of the primary. To preserve the cortical spinal tract, an initial stimulation intensity of up to 15 milliamperes is recommended, corresponding to about 10 to 15 mm distance to the cortical spinal tract. Once an MEP is evoked, the surgeon is alerted to the change by either a sound or a low-pitch built-in alerts system, giving the surgeon an estimate of the distance to the cortical spinal tract in certain machines. The stimulation intensity is then gradually reduced in 1 to 2 milliamperes, allowing the surgeon to continue tumor resection with caution. The surgeon removes the tumor at sites where no MEPs are triggered. The lowest motor threshold reached during surgery was found to be about 1 to 3 milliamperes. Finally, there are certain limitations to these methods. Animal studies have shown that high-intensity stimulation prolonged stimulation causes gliosis and neuronal membrane destruction, although this has not been conclusively shown in humans. The safe current density corresponds to 15 or 20 milliamperes, and this should not be exceeded in most intraoperative monitoring settings. More seizures have been reported with bipolar stimulation durations, and seizures are most common side effect, but they can be easily aborted with ice ringer solution. Coagulation probe artifacts intraoperative can occasionally mimic a real seizure, and there is a variation of after discharge thresholds over different brain areas. Consensus and definition of motor, language, sensory, and cognition testing protocols should be agreed upon before instituting surgery. So in conclusion, unfortunately, there are few high-level evidence or prospective studies to compare such effectiveness of intraoperative monitoring due to ethical concerns. But nonetheless, increasing experience in awake surgery is an advance to preserve function in functional neurosurgery. Motor mapping for cortical and subcortical structures, as well as preservation of higher functions, is now part of a routine management of patients with intraoperative brain lesions that require resection. It is important to bear in mind the differences in monopolar and bipolar stimulation, and when it is better to use the Penfield technique versus the multi-pulse trains technique. Preoperative, intraoperative, and postoperative phases have unique challenges, and there is ongoing research into the betterment of applying IOM in these clinical settings. Thank you for your attention, and we hope to see you perhaps one day in Singapore.
Okay, so thank you, Professor Low, for this comprehensive lecture. I did learn a lot. There are several questions on the chat box because the audience were mute, so I will ask by myself instead of them. And that is a question talking about Professor Low, do you routinely use awake surgery for mapping the eloquence area? As we know that intraoperative MEP and SSEP are quite very accurate in helping determine the eloquent area. If we are not interested in the language function, is awake surgery necessary for this kind of patients? We cannot hear you.
Yeah, okay, I'm unmuted. Yeah. Okay, can you hear me now?
Yeah, yes.
Yeah,
please.
thank you for the questions, Dr. Justin and Dr. Yu. Okay, the experience of my team in this form of surgery is very, very varied and not extensive. This is because the various surgeons have their own individual preferences with regards to the way that they manage. So what I have presented is actually a collection of current literature review of what has been written out regarding the basic principles and findings. And it is an area that is not uniformly used across the world, and even in a particular country or different health systems. So, for example, if you want to use subdural grid, there are costs involved. If you want to use a tumor that is more superficial, you might just want to use a pen field technique using the Orgiman protocol. And in some centers, there are a large team that also utilize various support staff like speech therapists, the psychologists, many different people. So I cannot say for sure which is the best combination, and hence I've presented. It's been extremely difficult to present a very uniform evidence of which is better. So, for example, another question is to use about the milliampere, the current threshold for epilepsy patients. In general, if in patients who have seizures, all I could say is that there is a lot more judicious in selecting the patient preoperatively, and also more discussion over the goals of the location in mapping and preoperative planning. And maybe there's a tendency to use a lower current. I cannot say for sure whether there is a definite milliampere that you use. Obviously, 15 to 20 milliamperes is usually what has been internationally regarded as the stimulation current that is the maximum. So I'm not sure whether that is something that all centers practice as well. It really depends on the resources and the team's preferences in the particular health system, and also funding as well.
Okay, so I think we have the question that is that another question is that is awake surgery necessary for patients? Those eloquent area is not related to language, like right side motor area. Is it necessary to do awake surgery for them, or we can just monitor the MEP, SSAP, and let the patient be sleep and sedated?
Okay, thank you. I think, to be very honest, awake surgery is not performed commonly in many centers, unless you are in a large country, for example, in US, where there is actually a central referral center. For many centers that have decentralized services, the experience is patchy, and it's, again, very localized to whatever the preferences of that particular system is, the healthcare providers. So we have performed awake surgery in situations where it is very near to the eloquent areas, but we do not have any data on whether it really actually result in a better outcome without comparing to a situation where you do not have awake surgery intraoperative monitoring. I know what you're saying is that whether preoperative planning and the current methods without intraoperative stimulation or grid stimulation will result in a better outcome. I don't think anybody has really presented convincing evidence to show either way. So again, extremely difficult to answer you. It really is a discussion in many different directions with different people.
Okay, so because the schedule is quite tight, I think I will finish this part and I will transfer this to Professor Ye for next speakers.
Thank you. Thank you.